Welcome to the Older Person in Pain Diagnosis and Treatment Conference Call. My name is Karen. I will be our leader for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Donna Thornton. Donna, you may begin.
Thank you, Karen. I want to welcome everybody to this call, and I'm excited to be able to share with you the expertise of our speaker today. Before we begin, I'd like to just let you know that if you go to the top of the page on your WebEx, you'll see a button to click on File, and you can save the document. That will allow you to get the slides as a PDF file so that you have access to them now during the call. So I'd like to introduce our speaker. Dr. Walter B. Forman graduated from Wayne State University and completed his training at Case Western Reserve University. In 1988, Dr. Forman came to the University of New Mexico Cancer Center to be its clinical director. Mini sabbatical in Oxford, England at the World Health Organization's Palliative Care Center with Dr. Robert Twycross led to his interest in the care of individuals at the end of life. He has completed a project funded by Open Society Deaf in America entitled Hospice Care in Multicultural Settings in Rural New Mexico. This grant was designed to teach hospice care in small rural hospices, to provide the latest developments in hospice care, and to understand the cultural issues concerning end-of-life care. Funding from the Robert Wood Johnson Foundation allowed them to expand their program to 7 sites and the Indian Health Service. In each of these rural areas now has a fully functioning hospice program. Dr. Forman served as treasurer and president of the American Academy of Hospice and Palliative Medicine. Other accomplishments include over 70 published articles and the editing of the textbook Hospice and Palliative Care Concepts and Practice. He has presented at numerous local and national meetings. As a Mayday scholar, he has developed conferences for the lay and professional groups concerning issues revolving around pain and its role in diminishing quality of life. Working as a member of the United States Pain Initiative, he has continued his interest in bringing the problem of pain and its various issues to the attention of the public. He helps found the New Mexico Cancer Pain Initiative, which has been instrumental in changing the laws in New Mexico concerning pain treatment and education. And I am so very pleased to have him with us today to share his knowledge with us about pain. We will have time periods intermittently throughout the presentation where you can ask questions, and we will open it up for questions, and there will be a session at the end for Q&A. If you do have something, you are also welcome to put it into the chat box as we're going through. So now I would like to turn it over to Dr. Forman.
Well, thank you very much. And, I'm not sure I know the person that you just introduced, but sounds good to me. Hello, everyone. I see there's something like 173 attendees. I hope I can address the issues that revolve around pain in the older person. Excellent. So what I'm going to try to do today is to help you understand what the problem is in an older person in regards to their pain and their ability to explain their pain. I'll say this now and I'll say it again. Most of the common issues of pain in the older person is they don't tell their healthcare provider that they're having pain. Why? Because everyone expects an older person to have pain. Isn't that natural? I'd like to talk a little bit about the pathophysiology of pain. We need to be quite aware that some of this is going to change for the older person. I'll try and point that out. There's different types of pain, and I'll give you 3 examples of that so you can see the difference. And finally, we have a whole conversation about pain treatment and the use of opioids and what's going on in our country right now. If you want to ask questions about that, fine. I don't plan to really discuss that issue, but I think you need to be, and I'm sure you are aware, that this is a major problem in our country, particularly for someone who actually has pain. So what about the the epidemiology of pain, and who claims to have pain? Notice that a good percentage of home health patients, and I'm assuming that you all have a few of these, have moderate to severe pain that's not being addressed. And I think that's very important to remember. And notice that even in New Mexico and nationally, that a very large percentage of patients with pain at the start of care improve while they're on home care. So this is a very important topic for me, particularly since I do a lot of hospice care. Does pain interfere with your ability to do activity? The answer is yes, and we'll talk about that again in a moment. Now, where is the group of patients that have the most pain and are getting the least care for their pain? I don't know how many of you do nursing home work, but notice that 83% of people in nursing homes have pain, and what happens to an older person, or anyone for that matter, that has pain that's unaddressed, their mobility is decreased, you just don't want to move because it hurts, and when you don't move and it hurts, you get depressed, and of course you can't do anything as far as your quality of life. So pain is a real important issue when it comes to the older person, and in fact, I should say that when it comes to anybody in general. I'm sure you've all had experiences with people with pain, and we'll talk about, particularly in the older person, what we need to do to help them. Notice that a large percentage of people noted in the MDS had episodes rated as moderate or excruciating at the next MDS assessment, and we'll go a bit into how to assess pain very soon. Finally, on this slide, notice 1 in 7 residents were in persistent pain. Well, what is persistent pain, and how do you describe that? What I like to think of as persistent pain is someone who has pain for at least 3 months, where the episodes may or may not be severe or debilitating or what have you, but that their pain is not being addressed, and thus they look back up to the top point, the quality of life is definitely diminished. Now, the hardest part about this whole thing, as far as the topic, pain in the elderly, is this particular slide. And I want to point out to you that you could talk about pain in any one of these groups. We're talking about seniors, for lack of a better word, who are 65 years and older. Notice that there's a whole group of people that I'm not going to be speaking about, and we can't really apply some of the things I'm saying to those folks. Obviously, an infant is going to have a different response to pain than a senior. And as you go down the list, I think you can all realize that the seniors sticks out in this regard. And the next slide shows what I would like to call presbyalgus. This is age changes that occur in the ability to perceive pain. Sounds silly, doesn't it? But there's much evidence to suggest that the older person may not feel pain as much as a younger person. And this has been done with things like electrodes, etc. And then we have another problem here, that old is not old. Just because you're 65 doesn't put you in the functionally inactive older person. So let's look at this particular slide. If you're 65 to 75, you're, quote, in the young, old group, generally healthy, active, and very much able to describe their relationship to the pain they might be having. Old, 75 to 90. I'm sure you've all been involved in this age group, and I think the important thing to recognize here is that the index of independence and mobility really decrease for this age group. What this means is that one really has to attack pain in this age group in order to keep them mobile, and mobile, as you must be aware, is critical for the old, because without mobility, their morbidity really does increase. And a good example of this, how about someone that's just fractured their hip and had been walking and getting around, doing their business. They're now in bed with a fractured hip. They need lots of physical therapy, and the incidence of death in this group in 1 year is about 30%. So even these kinds of things can lead to more morbidity in this particular age group. So this is a group that I think you should really concentrate on as far as pain. And the most difficult group of people to deal with are the oldest old, and that's 90 years and above. And as you all must be aware, this group has most of the illnesses that affect the older person. And because of these illnesses and the morbidity related to them, their ability to distinguish the kind of pain they're having and what works and what doesn't work as far as therapy, very difficult to manage. So we have on the three groups, as I've outlined them, two of the groups that are critical, the old, who really we must increase their mobility so that they don't become morbid, if you will. And the oldest old, 90 years above, who with pain really have a decreased quality of life. So what are the problems with an older person? Well, it's not just I hurt because I hurt. There's an increased instance of the number of different illnesses that we have. Spinal stenosis, I picked that one because most of us have problems with the lumbosacral area. It gets worse as you get older, and this is a cause of pain. And I bet if we interviewed all the attendees, we find that most of us have some sort of symptoms related to spinal stenosis. This is not an infectious disease. This is not something that is easily treated. Osteoarthritis, obviously, a very important part of pain in the elderly. Notice I've not listed the other kind of arthritis as a rare disease because that would not fit into what is most common, and that's osteoarthritis. Fractures, of course, a major problem as you age, particularly the older person. This is usually living alone, who fall and then slip in the bathroom. One of the most classic examples is the older person that gets up to go to the bathroom at night with no particular lights on in the room, has a nice area rug on the floor under their bed, and guess what happens? They fall and fracture their hip. So this is another health maintenance issue that you might want to be aware of. Why do older people report less pain? Well, I would say number one, we don't listen to them. In 20 minutes, and a person who's 85 years old you cannot possibly cover all the medical issues they have in the allotted time. And so they just don't bother telling you. They just feel that there's no sense bothering the healthcare worker with the simple problem of pain, since pain is just part of growing older. I'd like you to look at that quote and make certain that you realize that pain is not part of growing older and that we need to address it. As your cognitive functions decrease, your ability to report illness really also decreases. And so if you go into a Alzheimer's unit, dementia unit, you're going to find that very few people can tell you about their pain, and I may show you a way of assessing their pain. Okay, so what we did, just to get some idea of the state agencies that this group represents, we got 214 answers back. So I want to hit question number 1. As we age, pain becomes a problem because of our long-term use of our musculoskeletal system. True or false? The group said true. The answer is false. You don't get pain because your musculoskeletal system falls apart. You get pain because the other things that I've listed in the previous slide. So pain is not part of growing older. You might have pain as you grow older, but usually there's some sort of etiology. And it's not because you've been using your musculoskeletal system. And in fact, the disuse of your muscular system musculoskeletal system really leads to pain. Here's another question that we asked. The group of people under the age of 75 is rapidly increasing. And I was pleased to see that nearly 100% of the group felt that this was true. And that's one of the reasons why we're doing this presentation this afternoon, that this group of people, those over the age of 75, who are more likely to have pain, are going to be people that we see in our healthcare practice more and more every day. And the more you see of these people, the more careful you have to be about pain and its evaluation, and its treatment, of course. So, how do we assess pain? Well, I'm going to give you a very simple way of doing it. And that is, you ask the person, do you have, or have you had pain in the last week or month? The answer is no. Next topic. Don't pursue that issue unless you're concerned that they're not answering you truthfully. But no means no, and it's an important answer to get so that you can proceed with your assessment. And the assessment is the next step. Quality. What words do you use to express your concern about the quality of your pain? Does it ache? Does it hurt? I don't have a word for it, but I've got it. Is it pins and needles? These are the kinds of expressions that help you understand the nature of the pain. Not only is the person having pain, but the ability to know the nature of the pain. A good example of this is post-disaster pain, where people will have a variety of words they use for it, and I'm going to spend some additional time in a little bit talking about the word that's being used, or words, if you will, concerning the quality of pain. In order to determine the intensity of pain, you need to use the appropriate tool. Now, I know that pain is a vital sign, which I was very active in promoting, is now being used in most institutions I would say to you that not only is it being used, but now there's a whole movement that's saying it's a waste of time and we don't need to bother doing that. And I could take it off the records. But I would strongly oppose that. I think it's important to know the kind of pain, and two, to know how intense the pain is. Location is the key. Is it peripheral? Is it in the nerve? Or is it central? Is it upstairs in the spinal cord or in the brain? And that helps you then qualify what or where the pain might be coming from. Okay, some pathways. Pain is a common complaint in the elderly. Interestingly enough, most of you said true, but unfortunately, a third of you said no. But pain is a common complaint to the elderly if you allow the time for them to answer the question, or if you remember to ask the question at all. So remember that pain is a common problem in the elderly, and that it has to be addressed because of the circumstances that I've already described. I want the older person who we're caring for not to be hindered in their activity because something hurts. Now this is a real old diagram showing the traveling of pain. And notice how simple it is. You put your foot in the fire, it goes up your leg, around your back, and up into your brain. This is at least 150 to 200 years old and helps to explain how pain is transmitted to your brain. The next slide shows you a very complicated way of how pain is transmitted. And let me start with the bottom of this slide. Touch, pressure, receptors are in the sensory neuron. That's in the blue. They cross over into the spinal cord, spinal splenic tract, move upstairs into the thalamus, and then are interpreted in the cerebral cortex. So you can see that this is not a simple, and I'm making it very simple, but it's not very simple, way of conducting pain, and how you can see that there are many ways in which you can interfere with the transmission of pain by simply having these particular kinds of problems. For example, if you had a thalamic lesion, you might not be able to even perceive that you have pain. Again, a simplified view of this, it does become more interesting, as it were, if you would spend the time looking at the spinal thalamic tract. Does it mean that it's important clinically? Absolutely. Particularly notice where the receptors are and how they are then able to transmit the symptoms, so that if you burn yourself, you're going to get one kind of pain. If you cut yourself, you're going to get another kind of pain. I think we all can relate to that kind of pain. And all of it has to do with this very complex, simple mechanism of the transmission of pain. The best measure of pain requires an individual to pain to rate it. And I was pleased to see that 73% of you agreed that the individual has to tell you about the pain. And please don't forget that without the individual telling you what kind of pain they're having or how much they're having, there's no way that you can go about discussing pain. Now remember that if you want to know what their blood pressure is, you don't need them to say anything to you. You put the blood pressure cuff on, do the measurement, and that's it. But pain is not something that you can measure unless the individual measures it for you. And if you don't ask the questions, as I said before, you're not going to get a proper answer. So remember that pain requires the individual to state it, to then explain what it's like, and then to rate it. Next slide. When we get to the older person with pain, we've got a couple of problems that need to be discussed first. People with normal cognition. Well, who among us have normal cognition? Hopefully all of us, but you notice I have the word normal in quotes because there are folks that seem to be normal in their cognition, but are unable to deal with their pain because they can't vocalize it. People who are cognitively impaired also have the same problem, but they have a problem expressing their pain. And you need to know who you're dealing with. In other words, which kind of person, a normal cognitive person or a cognitively impaired person, in order to rate their pain. And a few examples of how to rate their pain. This is the most simple one. It's a 0 to 10, not 1 to 10, but 0 to 10 pain rating scale. You can simply say to the person, if you're having pain and 0 is no pain and 10 is the worst you've ever had, please give me a number from 0 to 10. Some folks like this written down. I don't. I think it's just simply having a person describe the pain and then evaluating it. And we'll point out why this is important when we begin to get to therapy. The next slide is another kind of pain. This is a long Baker faces pain. I love this particular approach. I use it myself. As far as I know, you can still get the Long Baker pain rating scale from Baxter Healthcare. I haven't looked at this for a while, but I would suggest that this is really a critical way, because this way even people who might be cognitively impaired can at least point to the face. So this to me would be the highlight of what you want to use for pain measurement. And notice it's fairly simple. 0 is silent and 10 is somebody crying. And notice the facial, the mouth expression as well. So again, let me say that this is the pain scale that I like the best for the average person that I see. Now, you're going to say to me, well, I work in a nursing home and lots of folks are cognitively impaired and there's no way they can give me a 0 to 10 or point out a face. So here is a list, and I hope you all got these slides so you can look at this and really spend some time with it. Vocal complaints. Well, that's easy. If someone's moaning, groaning, grunting, that suggests that they hurt. And notice we do it with movement and at rest. And all you have to do is check this box, whichever one of the two you like. Facial grimaces and winces. Again, clenched teeth, narrow eyes, furrowed brow. These are other important kinds of problems you're having with pain. I know now in a long-term care facility that you can see these kinds of things without persons having pain. Maybe they're just suffering from Parkinson's disease. So be careful with this one, but consider it important. Bracing. When someone can't move their arm or their leg, that should be a clue that there's something wrong. I think here the best example is the person who's lying in bed, not necessarily moaning and groaning, but when you examine them, you see that one leg is shorter than the other. and that's a good sign that refraction is hit. The person that I most likely see is the healthcare worker telling me that I can't keep Mrs. Jones still. And you can see the different kinds of things Mrs. Jones might be having. Well, this is a real good sign that there's something going on, and pain should be on the top of your list. Rubbing and massaging the area, of course, and then you might get a few simple expressions of pain, like ouch, or that hurts, stop, that's enough. These are kinds of things that you hear in the long-term care facility when people are in pain. So these are 6 simple ways of, if you will, measuring pain in the older person. Obviously, the more of these things that are checked as being there, the more likely there is a pain problem for the person who you're dealing with. One of the things we seldom do, and I'm obviously noticing that I hope you're noticing that I'm avoiding getting into exact information about pain and its pharmacology. And I want to do something that most folks don't do, and I'm going to do non-pharmacologic interventions before pharmacologic. Why? Because those are the most effective ways of treating pain. And this is not with a PRN physical therapy report. This is done as a routine. I'll show you the World Health Ladder in a minute. And decide on what you want this person to do. If there's no goal to what you want to have done, that is, you want their pain to go from 9 to 4, that's your goal, that's your therapy, and you can monitor that and evaluate that quite simply. And actually, there are charts that you can use where you can begin with pain as 7 over 10, and then monitor it as you add therapy, whether it's pharmacologic or non-pharmacologic. And here are some of the psychological methods used to teach people why they're having pain. And here's a bunch of things that you can do: relaxation, imagery, psychotherapy. But I think the most important thing is to help the person understand why they're having pain, why it should not produce anxiety, because you're going to help them relieve their pain, whether you use physical therapy or medication, and that they don't have to fear that nothing is going to be done with this. I noticed that many of us are easily swayed by a little bit of pain, and so you can imagine what our patients are going to be feeling. And here's a bunch of other things that are complementary that can be used. I'm not saying that they all work. I'm not saying that they all should be used. But I think you should give at least some attention to what kinds of things can be applied. And I'd like to say that acupuncture is maybe a very effective way for controlling pain. At least there's some recent articles that suggest that. I had a lot of experience with it, and do not think it's a very effective way. But again, remember that a third of people who you treat pain are going to have a placebo effect. A third of people with pain are going to have a placebo effect. So it doesn't make any difference what you do. A third of the time, it's going to be great. And that's why you see all these different kinds of therapies that folks use. But remember, there's no time they're having their pain anyway relieved, and not necessarily related to what you've done. Now, that doesn't mean that what you've done is stupid. What it means is that for that particular person, that's the best way to treat their pain and stick with it. Physical methods. Now, a lot of us send folks to physical therapy, and we write on the consult, pain in left shoulder, please do physical therapy. I think you should understand a little more about what's going on than simply that. You want the limbs to be stretched, you have particular exercises that you're interested in the person having. T.E.N.S has probably come and gone, but there are other methods of stimulating muscles and nerves. And most of us remember that you elevate or compress something in the leg, for example, you'll get increase in comfort. And massage, vibration, if you will, rubbing, if you will, all act to help relieve pain. And notice there's no medication involved here. My favorite one is heat and cold. And the answer is which one do you use is who's your grandmother. If your grandmother used heat, then that's what you should use. If your grandmother used cold, that's what you should use. But the rule is that for the acute 24 to 48 hours, you should apply heat to the painful area and then switch to cold application. Probably applying these devices 15 to 20 minutes every QID. And here are a few other things, and I know of many support groups that help people with pain. I'm not certain that the others will or will not work, but again, it's on the list of things that you might try for people with pain. Prayers are particularly important in folks who have orthodox points of view about the religion. So keep that in mind, although you might think it's sort of silly for a doctor to be saying that you should consider prayer. But when you're treating pain, there's nothing that doesn't affect the pain. And if prayer works, that's great.
Dr. Forman, this is Donna, and we have a question in the chat from Neil Benensky. I'm not sure I'm saying that right. I apologize. It says, I'm a medical director at a SNF, and we struggle with improving on the CMS quality measure for pain. We have tried numerous system and process improvement interventions, down in parentheses, pharmacologic and non-pharmacologic, and continue to not improve on our facility score. Inherent in the CMS QM is that the pain score greater than 5 triggers the negative metric result. We have found that patients really don't understand the true definition of the 0 to 10 pain scale, and associate scores that are much higher than what the face or cognitive functional would suggest their pain level has actually been. Any thoughts on this disconnect we are seeing and struggling with? Thank you.
Yeah, this is a very good question about what kind of pain to use in a long-term pain scale to use in a long-term care facility. And I would suggest to you that the Wong-Baker scale is probably the best. In that when you ask 0 to 10 of someone who's in a long-term care facility in general, and we publish this sort of information, they're not really clear about what you're, at least for this cohort, they're not really clear about what you're asking. And so their 0 to 10 score might not fit with a Wong-Baker scale. And again, the next problem is, have you trained your folks to use these kinds of tools? And at least I found that some of the training is poor enough that the folks go and say, hey, have you pain 0 to 10? And no matter what person says, I write it down and leave. And that's not exactly the way you want to present this. So, yes, I agree with you, and I would suggest that you put in the Wong-Baker scale and have an in-service so everyone's doing it on the same level. And we've used also, if you will, actors, local community people, to come in and suggest that they have pain and try and find out what kind of pain and how much pain the person is having. And you'd be surprised at how many of us can't figure that out in talking with the patient. Is that satisfactory?
Well, we'll see if he chats in or if he wants to ask a question at the end here. I was wondering if you would maybe say a little bit more about the setting of a goal with the person in pain and then following up on the response to the intervention, because it seems to me that that's maybe where there's a lack of follow-through is on seeing how well the intervention actually works.
Well, that's why I have listed all those non-pharmacologic ways, and you can't rely on pain being relieved by any one particular way. You might need some Tylenol or acetaminophen along with the physical therapy. The physical therapist has to then decide whether it's heat, cold, massage, etc., and probably need 2 or 3 or 4 different ways of approaching pain in the elderly. And we'll come back to that when we talk about therapy in a moment. In the older person, a trial period of a few days will help the clinician determine response to pain medication. Notice, 65% of you said that was true. And the answer is that it is true. That if you start someone on acetaminophen and you wait 48 hours and nothing has happened, then you've got nothing's happened in regards to the pain scale. Then you've got a pretty good trial going, and you can then change the pain medicine. So true is the proper answer to this. So let's talk about analgesics for a minute. By the step, by the clock, adequate trial for each drug. If the gut works, use it. Last one is most important. Don't go around putting patches on people and injecting them if you want to get a good evaluation of whether the analgesic you're using is working. Now remember, I'm not talking about post-operative pain. I'm talking about pain in the elderly who have had their pain 3 months or more. So if the gut works, use it, and make sure that you know the drug you're using so that you put the person on an adequate trial. 48 to 72 hours works quite well for acetaminophen, but if you're using an opioid, that might not be the appropriate time interval. Oh, and then there's a whole list of drugs. And I just want to point out to you a couple of them. You'll see shortly I say this again. Pick out the one that you're most comfortable with and learn how to use it. NSAIDs for the older person, I absolutely do not recommend. There's too much trouble with kidneys and too much trouble with the GI tract to use this drug. Acetaminophen works quite well for this particular analgesic. There are several opioids that are available. I like to use morphine and, when needed, fentanyl. And then there's a whole list of co-analgesics. I think you can see that on television where they're pushing a drug for neuropathic pain in people with diabetes. I'll leave that to your discussion and your thoughts. I don't think that's a particularly helpful approach. Tricyclic antidepressants, nortriptyline is my drug of choice, And I think the only choice of local anesthetic would be someone who has post-oxygen pain. Here's the latter. This is done by the World Health Organization in 1988, so it's a little bit old, but on the other hand, if you look at 1, 2, 3, you can see that nothing much has changed. We still use a non-opioid, we use a weak opioid for step 2, and a strong opioid for step 3. Notice I'm not using the word narcotic, I'm using the word opioid, and I'd like you to use that word because it makes a big difference in the field when you tell somebody you're going to start a narcotic as opposed to how you're going to start a strong opioid. Several drugs not to use. Demerol, no longer on the list as well as Darvocet. Now, I know you're going to tell me that you've got people that love oral Demerol or people that love oral Darvocet. Okay, but for general use, as I said, a third of people are going to have a placebo effect. For general use, these two drugs are of little value, and in fact, Demerol has a very significant toxic side effect. I don't like codeine because all it does is produce constipation. I've never gotten a dose that's good enough to give anyone pain relief. And tramadol is one of those drugs that may work or it might not work. You can use it at your discretion. One of the most important problems, particularly for people who are working in a long-term care facility, is finding a person with pain and then trying to get some help. So, this is my list of how to call the healthcare worker in charge of this patient. And who's calling? Identify the patient by name and diagnosis and make sure that they know who the patient is. Tell them what the pain issues are and what the management goals might be. Summarize what you've done to this point. List the current drugs that they've been receiving and what kind of side effects. For example, if they're receiving morphine and they're having terrible constipation, you need to address that in a minute. And then suggest a solution. Notice I said, if possible. And the review here is from the pain management and nursing facilities from Brown University. So this is just something you can look up. Brown has a whole website about pain with several different chapters that you might review. Dosing can be given in the early AM for a 24-hour response. I'm sorry that 24% of you think that's true. Dosing has to be done by the clock. And by that I mean people that take long-acting opioids are going to have a period of time in which the pain relief is not working. And so that you need to adjust your medication to fit that particular person. Remember, this is not something that can generally be addressed, but has to be addressed to the person you're dealing with. Guess what? Cocaine works great for two things. It's an instantaneous cure, and in 1900, this is 1895, so I'll say 1900. This was a drug that was available in drops, and we could spend another hour talking about the laws in the United States about opioids and what and how it's come about. But I just want to remind you that there is a whole history here of how to treat pain. what I'd like you to think about when using these drugs is who, what, when, and where. Do they have any illness? What route do you care to use? And can they afford the drug? Now, I said here that should have pain greater than 4 out of 10 in the past 48 hours to begin an opioid. You also need to make certain that opioids, non-opioids have failed. You need to start with an immediate release medication. Work with the person for 48 or 72 hours. Divide the dose into 12 hours apart in order to get the dosing for the sustained release preparation. This was taught to me by a pharmacist that I worked with for a while, and I would like to pass it on to you. Start low and go slow. Unfortunately, with most of the opioids, there's a tremendous problem with constipation, and there are now several new drugs that linaclotide, for example, that will help prevent constipation. I would even suggest that if you start the opioid, then you should start some sort of treatment to prevent constipation. Some people have nausea and vomiting when you start the drug. I found haloperidol to be a very excellent source of relieving this. Somnolence with methylphenidate, also a good drug for this particular problem, given in the morning. Small doses, 5 milligrams or so. The elderly are a real problem because morphine is metabolized to a 3 and a 6 glucuronide, which need to be excreted in appropriate proportions in order to have the elderly person get the benefits of the drug. And if they have renal failure, you're in trouble. Methadone, same issue. Long-acting, short-acting, never quite sure how long it's going to last on the person. I've seen studies from 72 to 128 hours for half-life. So I'm not happy about using that drug. Bioclonus, I think you can lay people down, ask them to close their eyes, and just sit there and watch them. You're going to find a lot of folks on opioids that have jerking motions, and these are the 4 drugs that are most likely to cause that. The latest and hottest number is to put an opioid with naloxone. And naloxone is poorly absorbed orally, Also, if you inject it intravenously, you'll get a very interesting side effect of immediate opioid withdrawal. So you'll find many new drugs now coming out with some sort of combination of naloxone and or naltrexone. Tolerance. Tolerance is the increasing dose to maintain analgesia. Someplace about 400 milligrams will suggest to you that the opioid is no longer working. Why? Probably has to do with the receptor sites. So in this case, when you hit about 400 milligrams of one opioid, switch to another opioid at 50% dose, and you'll find that this works quite nicely. Physical dependence, we all get, and we shouldn't forget that. If we stop the drug on Saturday night when the person comes in with pneumonia, they're going to withdraw. These two do not suggest that they are addicted to the drug. Addiction is a psychological dependence. The hyperalgesia we'll talk about next slide. Lots of words on this slide. Let me hit a couple that I want to pay attention to. Hyperalgesia relatively new diagnosis, maybe the last 10, 15 years, may worsen the patient's condition. And what this is the drug itself, in some strange way, is producing more pain. Probably the best treatment of hyperalgesia is to use something like an NMDAR antagonist. I would suggest that probably the thing to do is either change the opioid or take them off the opioid slowly in order to alleviate this hyperalgesia. Very common problem, just recently recognized. Now, here's the real issue, and this is from the Boston School of Medicine Pain Center. 71% of people have friends or family who have given them their opioid. Notice it's not necessarily a doctor's problem. If you add 71, 4.8, 4.4, you're going to find that 2/3 of the people, or a little bit more, are going to be getting their opioids from someone other than the doctor. So you need to watch for that when you're seeing people. Summary. Use a few opioids and comfortability with them. Understand toxicity, treat prophylactically, and make sure the patient and or the family understands what you're doing. If they don't understand, they're going to say to you, I'm not going to take this narcotic because I'll become addicted. And I hope this previous slide helps you understand the other causes that are not, the other causes of needing more drug, more opioids, are not related to addiction. For the last few minutes, let me spend some time on neuropathic pain. Neuropathic pain is associated with dull aching and loss of free movement of the area involved. This is absolutely not true. Next slide. Neuropathic pain, and it's down the bottom in red, is different than nociceptive pain, and it will be accompanied by what's called lancinating pain. And what happens here is the symptoms are transmitted from the painful area to the brain, but then there's a sudden disruption in the transmission of the pain signals back, and here's a list of diseases and or drugs that can produce the same problem. When you ask someone about the quality of their pain, burning, stabbing, shooting, gnawing are not nociceptive pain, it's neuropathic pain. And notice how many different ways this can occur. It can occur with intimacy as well as with eating. Notice also that with allodynia, light touch can produce pain, and I've listed some different kinds of hyperalgesia on the bottom part of the slide. People with neuropathic pain have motor weakness in the distribution of the pain. They might have decreased tendon reflexes, and they might even, in fact, have diminished sensation at that side. And so I remind you about an ill sign, tapping over the nerve. If you get a sign of pins and needles, then you're talking about neuropathic pain. When we talk about skin changes such as color and temperature, we're coming into a different pain disorder, and I'll talk about that in a minute. Many different reasons to have for neuropathic pain. There are just a few of them. And here's a list of some drugs that have been used for neuropathic pain. And notice there are all kinds of side effects. This is a very difficult illness to treat and requires really some expertise. But here's a list for you of drugs. I've also listed some complementary and alternative medicine similar to what I did for the nociceptive pain. I think when you're dealing with someone with neuropathic pain, you best have available as many different choices from different areas in order to meet that person's pain. But not going to be simply treated with the pain medicine. Complex regional pain syndrome, I just want to put this slide up so you can see it. There's two types. The first type is one that we most often see following an injury that didn't affect the nerve, but 90% of people who have complex regional pain will have this kind of history. This is also, if you will, a neuropathic kind of pain. Some of the illnesses that we've talked about before, rather than listed before, as causing pain. One thing about the future that I want to leave with you, and that is the concept of how opioids work are becoming more and more clear, and they're always working at the mu receptor in the brain, but how they work and whether one opioid is better than another is not clear, and then there becomes a whole other issue about endorphins. TLR4 is a brand new part of the immunity system, and it appears that the morphine-free glucuronide activates this during sepsis, so maybe an opioid is not the drug of choice for someone with sepsis. And that ends my discussion. This is from our balloon fiesta, which you're all welcome to come to. Some 700 balloons will be going up, and they have great food.
Well, thank you very much, Dr. Forman. We do have a question in chat from Pam Longmire asking about opioid-induced hyperalgesia. I'm not sure I'm saying that right, but.
Well, I think I went over that a little bit, and it is true that opioids, that's another eye, that opioids will, on occasion, produce hyperalgesia. Mechanism, as I said, is not understood, and the only treatment I know of is to change the opioid.
Okay, great.
Any questions?
Well, our time is pretty much up, but I'm wondering if there is anybody that might have a question that they'd like to ask before we close the webinar. I don't see anybody chatting in. I would like to offer that if you do have any questions, that you could either contact myself or your quality improvement organization, and you can forward the questions to Dr. Forman and get a little bit of a follow-up that way if we need to. And I want to thank everybody for joining us today. And Dr. Forman, thank you so much for sharing your knowledge with us.
My pleasure. Thank you for asking me.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.